Hello, everyone. Good morning.
Good morning, madam.
Okay, so should I say the first time or the second um time for surgery? Just that today is the first day of lesson. So per the outline that has been shared, we are to begin with preoperative preparation for patients undergoing orthopedic or neurosurgical or neurological surgeries. So it's just a general overview of what you are supposed to do or know for these patients. You have already gone through the general preoperative, postoperative, intraoperative preparation for patients undergoing surgery in surgery one. And so this is just about the systems we are to treat. The first two systems that are the neuro and the musculoskeletal. And I'm sure that most of us here also have nursed patients in that regard before, or we are still nursing some patients. And so we'd have a lot of ideas about it. Please let's feel free and ask questions or answer any questions um, thrown to us so that the class will be a bit of a discussion, a very great one. Okay. And if time permits also, we have 2 hours, 30 minutes. I'm sure group one is ready, right? I'm very sure you are ready. So I'll go through two presentations with us, and then group one will come in. If we still have time, then I'll do my third presentation, right? So we have the orthopedic surgery, we have the neurosurgery. And so generally, orthopedics, we know is a branch of surgery that, of course, deals with the musculoskeletal system, right? Yes, so it deals with both the surgical aspects and then the non-surgical approaches. Whenever there are bone deformities, whenever there are damaged bones, diseased bones, and all that, we have the non-surgical approaches they take to treat before going through surgery, unless of course some are just peculiar to patient being sent to the theater for a surgical intervention, but most of it we have that non-surgical approach to do our management, and then afterwards we can now shift to surgery. So it varies. We have the degenerative diseases, we have the tumors, we have the trauma. Of course, most of the orthopedic conditions are trauma related, most of it. And so even when you go to some hospitals, their directorate, they call it a trauma and orthopedic directorate, right? Or trauma and orthopedic unit. And so most of it are trauma related. Okay. Then we have the goals for these orthopedic surgeries. Of course, if it's trauma related, we should know that we want to relieve pain. We want to relieve pain. We want to maintain adequate neurovascular functions. We should know that whenever there's any orthopedic malfunction, their neurovascular status is also malfunctioned. They have impairment in sensation, mobility, impairment in blood supply. And so their neurovascular status is malfunctioning. So we want to either restore or maintain the normal neurovascular status. We want to also restore mobility. We want to improve joints or limb movement.
No, before I'm going to make me sound got to chin man.
How many reps do we have on the page? Participant.
We have
Uh, so we
it.
have
Yeah.
Emmanuel, right? Emmanuel Arthur.
Yes, madam.
You are going to do this for me. If you don't do it, and I note it down, it means that you are going to refer my surgery, right? And
Okay.
so do this for me. Whenever anyone consciously or unconsciously talks in my class, put their names and index numbers down. Right after the class, send it to me. Take my number. I don't know whether you have it.
Yes,
Take my
madam.
number and send it to me. Yes, send me a message before, because if you call me, I don't have your number, you won't get to me. So do that, right?
Okay,
Yes.
madam.
And
Oh,
please, if you have logged in with just your name, log out and log in. When I was logging, I saw somebody Mavis with some emojis. I'm not going through all the names here. We are to be disciplined. I said last week that from this moment, any class you would want to go to, any degree program you want to do, there will be an aspect of online, right? So learn to be disciplined. Always be checking on your phones, your laptops, and all that, so that you don't get issues with anyone. So, Emmanuel, my dear Emmanuel Arthur, please do that for me. Otherwise, I have your name here. I have your index number here. You are a co-host as well. And so I will deal with that personally. Thank you. Right. So,
madam.
yes, so we're talking about the goals of orthopedic surgery, right? So we want to also, of course, maintain patient self-esteem. Imagine you are there, you can walk well, you can do whatever well, and then suddenly there's maybe an accident, a fall, whatever, right? And so, yes, it's a problem. As well as also improving patients' quality of life, correcting deformity, and then facilitating um, healing, promoting proper bone healing after the fractures, whether they're ligamental tears or any other injuries, we want to do that. Then we come to neurosurgery. You come to neurosurgery. You see, generally, neurosurgery also we know is specializing in what the nervous system, right? The disorders of the nervous system, the brain, the spinal cord, including the peripheral nerves and the cerebrovascular system. And so, spine-related tissue, trauma-related issues also as well, fractures as well, spinal cord injuries, um, tumors as well, degenerative disc diseases, stenosis. Yes, some of you would present on that for us. When we want to do brain surgeries, we want to address head injuries, we want to address tumors, we want to address vascular disorders, even hydrocephalus, epilepsies, and the rest, we want to address that. So neuro is quite a bit diverse and quite complex, right? And it's a bit of a challenging specialty. And so for neuro, but it's even quite difficult to get a lot of neuroscientists and the neurosurgeons to treat us. And so mostly the hospital I left before here, for neurosurgical clinics, we always close late in the evening. OPD, we can close somewhere around 9 p.m., even 10 p.m. And then the surgeons are really, really limited. Generally, these managements of neurosurgical patient, orthopedic patients are not different from other surgeries. We should know that they are not different from other surgeries. Whatever principles that you've learned all holds here. But one thing differ within the orthopedics and the neurosurgical cases or their surgeries. One thing differ. They mostly have implants, foreign bodies used in the surgical conditions. And so one key thing we should know of is infection prevention. It is really a key. Infection prevention, you should know that. And so, yes, for goals for these neurosurgical conditions, also we want to relieve symptoms, we want to restore function, we want to prevent disease. No, is it by force to go to church and go to school? Leave the class and go to church, eh? Or anyway, log out. Church. After church, you can come home and then take your notes if you want to. If you don't want to, it's up to you. It's not by force. Those of us who didn't go to church, like me, for instance, I'm teaching because, yes, they definitely I can't go to church and teach. It means I'm a Satan, right? Anyway. Yes, so I think I talked about a bit of these indications for both the orthopedic and then the neurosurgical conditions. Trauma as a key here in terms of the causes. Then deformities. Some patient would, especially for kids, right? There wouldn't be any having any trauma-related issues, but then they have a bit of a deformity which needs to be corrected. Joint conditions, joint diseases, any necrotic or infected tissue. I'm going to talk about osteomyelitis right after this, and then tumors. Then for the brain disorders as well, we have brain tumors, we can have the benign, malignant, that ones we do it in head injuries. Brain hematomas, epidural, subdural, all these things we want to do surgery to correct it. Yes. Spinal disorders. We have the spinal cord compression, herniated disc, stenosis, peripheral nerve disorders. Also, we have the neuropathies, right? And then the cerebrovascular disorders. We have the brain aneurysms and then arteriovenous malformations, hemorrhagic stroke, intracranial bleeding. They are all there. And I'm sure that you did some also in surgery 1. Frequent surgical procedures. Frequent surgical procedures. We have the ORF, open reduction and internal fixation. You see, they would want to do open reduction more of surgical, right? Of course, frequent surgical procedure. So surgery, they open up and then if they have to reduce it, we'll do that in fractures or fracture healing. Yes, we will reduce it, put the bone in correct alignment, and then they plate in or they put in an implant or a plate or a nail, right? Yes, and it brings us to what I am nailing. We also have close reduction. I took it out from the slide, just this one, because I realized that close reduction is more of there's not necessarily a surgical procedure. It wouldn't be an open surgery, but yes, manually they would have to reduce the bone, put it in a position, and then maybe put in the cast, right? Yes, a cast to just put in alignment. So I just feel that it's not necessarily a surgical, it's a non-surgical approach. So I took it. Yes, and then we have joint surgeries. We have to arthrodesis, arthroplasties. These ones also we do them, treat them separately. Amputation, and then we have wound debridement. And so mostly these procedures are based on the patient's underlying condition, orthopedic condition, right? And then also basically they are also their general health as well, because it also will determine whether we have to do this type of surgery for the patient or not. And then the impact of patients that disability on their normal living or their daily routines. Age is also one of the factors. Now, the frequent neurosurgery procedures. We have the craniotomy, we have the tumor resection, we have traumatic brain injury surgery. We want to do spinal fusion, where we have to join 2 or more vertebrae, right? And then laminectomy, you want to remove the lamina, and then discectomy or dissectomy, I don't know how you have to put it. So any damage or herniated disc. And then mostly we, the nurses, and then like health care workers, I don't know whether because of our positioning, the way we we don't really do our body mechanics well when we are carrying our patients, when you are lifting them. And so try your best not to do that. I don't know how to, I would use this in English, anymore, where you'd want to people pleaser. I can do the work, I can do the work, and only you won't want you have to go and then raise or lift a patient up and all that. And then at the end of the day, when you have issues, trust me, neurosurgical conditions and even orthopedics, they are very, very expensive. Even to get to the specialist is a problem. And after getting the specialist, even running labs and all that are very expensive. And so the surgical condition itself is expensive. So be careful as to how we manage our patients on the ward. Right. So nursing management. These ones I know we all have ideas about it. I'm sure I'll let you come in very soon to talk about a few things. We want to do history taking, right? History taking. Nurses also, we don't really like history taking. More normally, I don't know whether it's changed though, but on the wards, what happens is that when the patients come, we take a little bit of the history. Oh, okay, so what brought you here? Blah blah. There's some few things, and we just take it for the sake of that, but not necessarily recording it. And so when you want to write our report, it is rather the patient's folder or their limbs or whatever we open up, and the history that has already been taken in there. That is what we write. So we have to do proper history taking so that at least if there's a bit of conflict with the history that has already been taken, we know how to address it, right? And history taking is one of the key things to know your management, to know the actual cause of the patient. The labs investigations are just a bit of additions, right? So we do a good history taking and then proper physical examination, and be able to get a bit of a query on how what is wrong with the patient. Education and counseling is really key to these patients because they now would have a lot of adherence. They have to follow some treatment regimen, and so they really need to be educated. And also based on maybe self-esteem, body image, quality of life, and all that, they need to be educated and counseled. Emotional support you have to give to them. We have to assess them psychologically, yes, by questioning them, observing them, yes, and we'll be able to know if they are okay or not. We want to also address fear, address anxiety, and then see how best patient can recover from surgery. Because if you don't address all these things, then after surgery is going to be a bit of an issue. Then the physiological, I said all these things are a bit of repetition from your surgery one. So you do your history and physical examination again over here. It's very, very key. You want to do your diagnostic investigations. You want to correct fluid and electrolytes. And so after you've done your investigations, your diagnosis, whatever outcome that comes out of the results, and you know how best you can correct any deviation. You want to correct blood volume. We should know that for orthopedics and the neuro surgery cases or condition, their surgery, they lose a lot of blood. They lose a lot of blood. They lose a lot of blood, especially with the orthopedics. They lose a lot of blood. About 1,500 ml of blood is anticipated to be lost during the surgery. And so mostly also we want to do their grouping and cross matching for them, and then get about 3 pints of blood in waiting for these patients. And so correction of blood volume is needed. Even before that, if their HB is low, it has to be corrected before we send patient to the theater. It's really key. And sometimes you'll say, oh, I'm okay, I've paid my surgery bills and I've done labs, blah, blah, blah. But up to now, they haven't sent me to the theater. So we as nurses, we have to also reinforce this education to them, because if their HB is low, we may go and then have a bit of a complication over there for them. Then you want to maintain adequate neurovascular function. adequate neurovascular function. Yes, I think, let's see if I have a slide on diagnostic. Okay, I would have made you come in to tell me more about them. Anyway, so we want to maintain adequate neurovascular function. Yes, so like we want to assess pain corrected, we want to assess temperature corrected, we want to assess sensation and corrected, you want to paralysis, pulselessness if they are there or not. All these things are things that we are going to do also when we are talking about fractures, right? I think the fracture healing. Then curing of infectious process, pain management. Pain management is also key over here, both the pharmacological and non-pharmacological management. And then informed consent, preparation the evening and morning before surgery. All these things are just a revision for us. And so in terms of the education, what do we do? What do we do? We educate patients on personal hygiene, on surgery and what to expect, adhering to the treatment regimen, pain. They are already in pain. All these patients, they have pre-pain experience, right? And so we have to really talk them into it, and then what to expect also after surgery, wound care, physio reviews, follow-up care is very important. Treatment adherence is very important. These patients, you see, most of us, I'm included, I'm sure we are all part. When we are not well with giving us medication, especially with these antibiotics, for instance. When we take it, if we get to the last dose, we don't want to finish up, we think we are okay. But you see, we need them, we need to finish them. And more of these surgical conditions, they are put on long-term antibiotics, right? It's not just that 1 week antibiotics that is given, mostly 2 weeks or more are given. And so they need to, even on this chart, they need to follow this treatment regimen and then count for follow-up care reviews. We also have to educate their family members. They are part of the care. And so for diagnosis, FBC, clotting profile, sickling, BU, creatinine, LFT, these are general diagnosis for all patients undergoing this condition, these surgeries, right? All patients. Some basically, because of the condition, what is affected, maybe it's cerebrovascular, and so they would want to do ECGs, echocardiogram, chest x-rays. Others also, because especially with these echoes and then the chest x-rays also, patients above the age of 45 years would want to do whether they have vascular conditions or not, right? Yes, so depending on the underlying condition, underlying factors, we'd want to do some of these labs. So these are all general, right? These are general. Okay. And of course, if there are trauma, there's infection, there's inflammation, right? So we want to do FBCs, we want to do ESR, we want to do CR protein. It's not part here. Yes. And then the BEs, the LFTs, the sickling. MRI is also key over here, CT scans. We want to know the detailed imaging where what is affected, right? CT scan, we want to find out the cross-sectional involvement of wherever we are taking, whatever shots we want to, is affected, you want to find out. And then I think we've talked about the grouping and cross-matching. All right. Their medications. Before surgery, we give them what? Antibiotics prophylaxis. Before surgery. It is given before, and of course, our surgery, we give prophylactic shock, shot. But then for orthopedics, it is given not just that an hour before surgery, right? It's not just an hour before surgery where you give that prophylactic shock shot, but you have to give it 24 hours earlier, 24 hours earlier or more, or should I say later than the 24 hours, depending on the state of the patient. We give DVT prophylaxis also depending on the patients above 40 years, patients who are obese. We want to give DVT prophylaxis, right? Analgesics, and then if they have any chronic conditions, also their chronic medications, we want to give it to them. Preventing infection, we've said that infection prevention is key in these surgical management. So when patient has underlying conditions and they have some sort of infection, FBC is checked and then the WBC counts are high, any infection that occurs 2 to 4 weeks before the planned surgery would have the surgery to be postponed. Treatment should be done. Labs should be done again for the results to come back, should I say negative or normal, before we proceed to do surgery. Because these conditions or these surgical managements already are prone to what? Infection. And imagine the bone, the brain, the spinal cord. If there's any other infection, it is really a problem. Healing becomes very difficult. And so we always would have to treat infections, postpone it before surgery is done. Okay. You want to do pain management. I know pain, we are good at managing pain so much, both the physical pain management, the psychological also we are good. But for oncological, I don't know whether we are still doing what comparison. Oh, this patient came in with the same condition, or we did the same surgery. The patient is not complaining about too much pain, but you are complaining too much. I know now we are so matured that we don't do these things. So yes, so both the pharmacological and non-pharmacological pain management are key over here as well. Right, nursing diagnosis. I'm sure now you have stopped, you know that we have new NANDA, right? When you get to 400, you do what we call, you do a course called nursing practice where you'll be taught through the nursing process well. You realize that we have new changes. I'm sure some of you haven't taken a chance to go through nursing diagnosis even after you were done with nursing training. Some of you are done with nursing training about 10 years ago, 15 years ago. So it's going to be a bit of an issue. Please get the new NANDA 2024, 2026 NANDA. And then now the diagnosis have changed. Now we don't say is it knowledge deficit? Even that one is it's old. And then it came to deficient knowledge. Now we say inadequate health knowledge, right? Yes, and you want to educate patients on that. And so these are all new diagnoses that are here. You can go through it. Any questions? Okay, so let me go to our next presentation here. Oh, Bernard. Yes, my dear. And then afterwards, Clinton will come in. Yes.
Good morning, Mom.
Good morning, my dear.
Okay, please, in your presentation, you made mention that before surgery, when the patient is having an infection, the surgery must be postponed for if the infection is for some couple of weeks. Please, I didn't get the number of weeks. If you can kindly do that for me.
Okay, thank you. 2 to 4 weeks, generally. That's a general, I don't know if depending on the patient's condition, can be extended, but it's within that time frame.
All right, thank you.
Thank you too. Clinton, yes, my dear. Yes, so Steven said it depends. Yeah, depending on the patient's status and health, but the general one is what I have said. Yes.
All right, Madam, thank you very much. Please, when we went to the nursing college, we're taught that some of the nursing diagnoses, for instance, like pain and fever, you don't need to relate it to anything. They can stand on their own. I don't know if that one has changed. For instance, you can just say pain as a nursing diagnosis. You don't need to relate it to anything. Has it changed, or maybe it's still like that?
Okay, thank you. You do it more in 400, but at least let me just generally talk briefly about it. Pain stands on its own, but now we have acute pain or chronic pain. You don't just say pain. No.
Okay.
Only
Okay.
pain is wrong, but acute pain and chronic, it stands on its own. But then there's a relating factor. And then currently there's also an evidence factor. So now we don't write two-way nursing diagnosis anymore. We write what I showed is just the diagnosis. There should be a relating factor. There should be an evidence, right? Related to maybe acute pain, related to maybe surgical incision, as evidenced by patients reporting of pain, or as evidenced by patients grimacing or patients guarding body or something like, yes. All right, so I think as I said, you do it more in 400. Sister Sarah, so Sarah will come in, Samuel will come in, and then Jim 4, then we end it so that I can go to the next slide. So 3. Yes.
Nancy, good morning.
Yes, my dear. Good morning.
Please, I know a friend that did an orthopedic surgery, and
Mm-hmm.
I think last year, and he was telling me that the surgery depends on um your money, literally.
Mm-hmm. Mm-hmm.
So he was saying there is a type of surgery where they do it for you once, but it costs high, and they have to use real imaging at that time of the surgery. And then they also have one that um they use just the x-rays. So if you take another x-ray after the surgery and it wasn't corrected well, you go back to theater. Please, how true is that?
Okay, I don't know if I got it, but generally orthopedic and neuro cases are expensive. I think I said it earlier on, very expensive, yes. So if you don't have money, it will be difficult for the right surgery to be done. I think that's what she said, yes. And so there are alternatives. Very soon, I think maybe next week, we are going to talk about common joint surgical procedures. And there's one called we have the arthroplasty and we have the arthrodesis. Arthroplasty is very expensive, and after healing, you just have your normal life. Even though, of course, there's a bit of pain and other things, generally, of course, you can't compare it to when you didn't have surgery. But then it's expensive. So most patients would now want to choose maybe arthrodesis, or most surgeons or healthcare workers will choose that for the patient because there's no money. But then for that one, the joints are immovable. So it'll be difficult for you to now move the joint because it's just a joint that has been fused together with pins. But then for the arthroplasty, is really the implants, the foreign body that seems like a ball and socket that has been put together. So it depends. And also there are some surgeries where you have to open up, go into it, and then do your thing. Some surgery that would need as they termed it, X-ray, like a fluoroscope, where using that screen, then they will be doing their own thing in the bones, or well, of course, we are talking about bones, so in that one, it depends on the type of damage that has been caused. It is either done perfectly well because of the damage, the extent of the damage, or there are some also because of the extent of damage, you need an open surgery, but because there's no money, they would want to do that. So it depends. Some also, the fluoroscopy is rather quite expensive. So yes, as I said, it depends on the state of the patient, the condition, the patient's financial status. But in all these, the financial status is really a key to to treatment. Yes, to treatment. Okay, thank you very much. So Sami coming, Karen, and then relief. Let me see if I can start sharing.
Good morning.
Next one. Yes, my dear.
Please, about the medication. I saw maybe medication for DVT. So in my mind, maybe someone going for a procedure,
Mm-hmm.
and these DVT medications are mostly anticoagulants or blood thinners. So is it advisable they give it before the surgery or after the surgery?
Yes, I get your question.
What?
That's great.
Okay.
I get it. Mostly, or I should let somebody come in. We give it, and then before surgery, we stop. After surgery, then we begin. I think 24 hours after surgery, it has to be started. Yes. So
Thank you,
you
madam.
see, most of these patients, unless it's an emergency right after they come, right when they come, we send them to a theater. But most of these patients, they are managed pre-surgery for a while. And so whilst they are bedridden, they are in bed, we don't have to leave them like that. So we give that shot. But then when preparation are underway to send patients to theater, we have to hold on. And then after surgery, we give it again, right? Okay, thank you.
Thank you, madam.
Let's now go to Karen coming. Let's now go to osteomyelitis. I think that one
Good
also.
morning, madam.
Yes, my dear.
Please, I wanted to know prevention of infection for orthopedic surgeries. So, mostly they are giving antibiotics before when you have infection, before and then after you continue with the antibiotics. I wanted to know. I know that when you take antibiotics for some time, your body gets used to it. So the person taking the antibiotics for some weeks before the surgery and then after the surgery, is it right?
Yes, yes. You see, these patients, yes, I get you. Your antibiotics, we have some, we have resistance and all that. So for these patients, mostly we go to you did pharmacology, is that third generation or first generation? That one, honestly, you have to help me in. But it is the close to the high, is that second generation, right? Cetrizone, or better still, I don't know if we have vancomycin in our system here, but we give that shot. Then afterwards, we want to stabilize the patients. When they are going to take it for a long time, then if it is flucloxacillin or what? Yes, or currently they give even is it what? Amoxiclav. Yes, so amoxicillin plus clavulanic acid or clavunacid. I've forgotten, but you did pharmacology better, so you can help me. Yes, so it is that short. It is not the antibiotic that's is quite low. It is the highest, close to high. So the second generation antibiotic that is given, and it's given for that kind of period where it wouldn't cause any issues. But you see, mostly for health care, if
Madam,
we give these medications, they weigh the risk and the benefits. So if the benefit is higher than the risk, then that's the most important thing. Yes, amoxiclav, broad spectrum antibiotics. Yes. Test stockings, yes, the patients can be on it before and then also after. I think when we are going to talk about post-operative management, we talk about test stockings, but it's good you brought it out, Ophelia. So we give patients wears compression stockings, that brown socks thing. They wear it before and after surgery as well. Samuel, is it third generation? Help me, that one I've forgotten. So yes, if it's third generation, that's fine.
yes, madam. Ceftriaxone is third
Third
generation, and then
generation, right?
Ceftriaxone is second generation.
Okay. Okay, so third and second generation antibiotics we give to them. Okay, thank you very much for that. I'm grateful. Okay, so can we go on, Regina? Is there anything you want to add? Or we have a lot. Can we go on?
Yes, madam. I wanted to add a little about
Uh-huh.
the antibiotics for the orthopedic patients. Normally, we give broad spectrum antibiotics. Mostly it's for prophylactic purposes, not to treat any infection, but to prevent any infection. So normally they don't take it for a longer time, unless maybe there is underlying infection already. Right. Other than that, we just give 24 to 48 hours, then it's
Yeah,
stopped.
for the prophylaxis, right?
Yes, madam.
Okay, okay, okay,
Thank you.
thank you. All right. So, can we move on now?
Madam,
Also,
please, I have
Yes, a question. Come in.
Yes, madam, please about the blood thinners, the anticoagulants for orthopedic patients. Madam, please, I want to find out. For instance, a person has been on, for example, placing 3 or 4 days before the operation or before the surgery, and then after the surgery, post-operatively, they gave an oral anticoagulant. How long should the person be on this oral anticoagulant? Because on prescription, it's like it lasts for about a week, and this patient is mobile, moving around. Should the patient take this anticoagulant for that long, please?
So mostly what happens is that these patients, we also have to, it's not also have to, we monitor them. Some takes the anticoagulant for a while, but always we have to monitor their INR, mostly, yes, the international normalized ratio. We monitor that for a while. Yes, so when you monitor, you know where the patient fits and which dose of anticoagulants we give. And mostly we give the warfarin, right? The oral. And so always they have to come for monitoring of the INR. So we know whether we are not giving too much or too low. Maybe you can go and read more about that as well, right? Okay,
Okay,
thank
madam.
you.
But my concern is the fact that the patient is in discharge third day post-op.
Yes,
And
so when they are discharged, they are supposed to come in for monitoring. But you see, that is one thing in our part of the world here we don't normally do. And we just give them maybe a week review or 2 weeks review. But they are supposed to be monitoring all the time so that we know the amount of oral anticoagulants to be given to them. Yes. So, but basically after that, after a week, unless the patient is bedridden, they are supposed to stop taking it. Some patients, if it is cardiovascular conditions where we've done maybe a neurosurgical case, neurosurgical procedure for them, then they take it for a while. They take it for long. Yes. So if they take it for long, then it means that they are supposed to be coming for monitoring all the time, and then we'll be adjusting the doses for them, right? Yes. Okay. So maybe we can.
madam, thank you so
Yes.
very
Yes.
much. Thank you
Okay.
very much. But madam, please, there is another issue that I want to find out. It baffled me. This was a personal experience. And patient had a bone fracture. And when patient was brought in, just that the second day, the patient started spiking temperature. So the doctors were like, maybe uh, malaria. So they did all the labs, including the full blood counts, to check out for infection and other things. But they all turned out normal. And second day after the fracture, the patient ran into rigor. Like the patient was having rigor with high fever, high temperature. So they started treating malaria, blindly because there was no parasite. So there was another prescriber who was of the view that it could basically be an inflammatory process. But here's the case, they were giving IVP more, but still the patient keeps having the rigor. I thought of it for a while and I didn't understand. So I made my mind that when I come to surgical or medical nursing class and there is orthopedic issues, I will ask about it. So, madam, if you
Okay.
can help.
Okay. Please, who will come in to help us? Why patient has fracture and then after 24 hours, patient started spiking temperature, later rigor, medical, physicians were treating for malaria, and then later somebody said there was an inflammatory response. Who will come in? Clinton, are you the one? Do you want to come in?
Yes, madam.
Yes.
Listening to her, for me, I suggest it could be infection. because there's fracture, there's break in the continuity of the skin, and there could be infection that is sparking the temperature. That is what I suggest.
Okay, that's great. Thank you. Who else will come in? Cecilia said they have to start with amoxiclav. Yes, my dear Joshua.
I can also say that for 24 hours, it's too early for infection to set in to cause hyperthermia. So it might be other causes. Like the patient is not, I don't know, it's not there that we can rule out some other conditions or other factors. So we can't say much.
Okay, thank you, my dear. Who else? One
Oh,
more
yeah.
so that I can just wrap up.
Please, madam, good morning.
Yes, good morning.
So please, I also think that when there is a fracture, there is going to be an inflammatory process. And then we all know that when it comes to inflammatory process, we have this high sparking of, we will say high body temperature, we have that of the pain, we have that of the swelling. So because there is damage to the tissues from the broken bones, that's why I think these signs were seen in that patient. So it was as a result of the inflammatory process that was going on. And then I also think that infection could have also set in because in our blood, we have a lot of these microorganisms, though maybe they may not be harmful when they are in their normal environment, but a situation whereby the environment is altered, they then develop a new characteristics in causing harm or damage to their surrounding. So if there is the break in the continuity of the bone, it gives access to these tiny microorganisms that may be part of the waste that is going to be taken out of the body. They will just invade into these broken bones, and then they will start causing this inflammatory process will set in, and then so I think infection could also be a possible cause of this. So thank you, madam.
Thank you too. So I think Joshua, right? I think you've summarized everything. So if inflammation and how should I say? Inflammatory response or inflammation, yes, an infectious process, they overlap. Even though, yes, inflammatory response sets in before infectious process. Mostly when you read more on inflammation, you realize that as is it Joshua, or the last person who said was talking about the enzymes and microorganisms. Yes, so these enzymes, we have the neutrophils, the macrophages, the lymphocytes, and all that. It depends on each stage where each one comes in play, right? And so mostly, which one comes in first? When they can't do their job well, then they die. Then they mix up also with the others or the foreign bodies and then the debris and all that. And then others also sets in. So the organisms are a lot, the enzymes are a lot that comes in play when there's inflammation. And so within that stage also, there's that overlapping of also infectious process. So it could be, as they say, it could be an inflammatory response. Yes. So, but when these things happen, when patients have fractures, um, generally breaking the continuity of a skin or a bone, when there's a break, we should start patients with antibiotics. That's the key thing. I don't know why they were thinking of what? Malaria. The other one, I don't know why they were thinking of malaria.
Madam,
But
please,
we
that
should.
was because they had already given an antibiotic before the patient ran into rigor.
Okay. They've already given antibiotics. Maybe it also depends on the antibiotics that was also given. So more of inflammatory response. 24 hours is neurogenic shock. Well, negligent from their side, 24 hours too early for systemic signs and symptoms of infection for localized. No, it depends, my dear. For 24 hours, it's not too early for systemic shock. No. or signs of, no, it's not too early. It depends on the extent of the injury, right? The extent of the injury, 24 hours is even lengthy. All right, anyway, maybe you can go and read more about these things, but it will be more of systemic response, inflammatory response. All right. So osteomyelitis. I'm sure that all of us here have met it before. We've nursed osteomyelitis before. What is it? What is it? We know that it is an infection, itis. I'm sure you met it in surgery one, itis, inflammation, right? So osteo derived from the bone. So osteomyelitis, inflammation of the generally or infection of the bone marrow. Yes, and then also you can have the surrounding tissues as well because it is also affected. So you see here the picture, you have the bone, we have the over here where you have the arrows, we have the metaphysis, we have the intramedullary cavity where you have the bone marrow itself, where there'll be pressure when there's infection, there'll be buildup of pus, abscess inside the intramedullary cavity, and it will cause pressure. Now the pressure will now build up or would attack the blood vessels. It will push the blood vessels, and so there will be narrowed off blood circulation through that area. Abscess formation still, pus formation still, and then there will be ischemia, necrosis, and bone death. So generally, you can see that there has been pus here on the second picture. There's that pus formation that has caused brittling of the bones. There is decreased medullary cavity because there is pus, there has been abscess. And you see the bone is not like the skin where it expands. So the bone cannot expand. So when there is buildup of the pus, it was still being packed in there, right? And so there'll be pressure within the intramedullary cavity. If it is soft tissues like the skin, you see that there will be the abscess will cause the skin to be widened or swollen. Yes, but then for the bone, what happens is that because of that, there'll be that kind of impaired blood supply, the necrosis, and then there will be an opening through to the soft tissue where gradually the discharge or the pus will be forming or will be oozing out. And so when you check on these X-rays images, you see that on the X-ray, you see a small hollow, should I say cavity, a small hollow thing there. That is where mostly the discharge comes from. And so you realize that there are some patients who have some wound, you dress it. The wound is healing. But I get to a point where now it's only some small, just as maybe a 1 centimeter thing, or maybe even 0.5 that will be found in there, and then it will be discharging. You dress and dress and dress. When you see something like that, then you should know that it is osteomyelitis infection of the body. And mostly also, if you see that and it affects, you see that in kids, in children, then you just have to quickly suspect osteomyelitis, even before these other investigations. Of course, investigation will confirm that, but when you see this, then you should know that patients has infection of the bone. So a severe infection of the bone that's characterized by what? Inflammation, necrosis, and then yes, there's a new bone formation. So infection of the bone marrow, and then the surrounding soft tissues, and then patient would have what? Infection, patient will have necrosis, and it's just about bone healing. With bone healing, when that thing happens, there will that be new bone formation to cover up. So always with osteomyelitis. And so with osteomyelitis, there is a formation of new bone called the involucrum. We have their causes. we have pyogenic, and for pyogenic, mostly the causes is the most organism that causes a lot of harm is what the Staphylococcus aureus, right? Staphylococcus aureus, and so you have the Staphylococcus aureus. Yes, you can still have the Streptococcus as well, and then gram-negative organisms. Non-pyogenic, we have the Mycobacterium tuberculosis, we have the fungi, yes, the Candida. You can also have that as well. All right, so risk factors. Risk factors. On the wards, patients who come in with osteomyelitis, what do you think are some of the risk factors? We have the malnutrition, we have age, yes, extremes of age, obesity, chronic conditions, patients on corticosteroids, then immunosuppressants, bone surgery, children, and then poorly managed fractures. Can we move on? All right, so you have stages. You have stages. All right. Stage 1, stage 2, stage 3. Acute fulminating. When you talk about fulminating, very severe, and it occurs rapidly. It's rapid, and then it's progressive, right? And so of course, it's acute. When it's acute, it means that in a short while, patients will have these symptoms. Patients will have a severe, rapid and then progressive bone infection, and then bone marrow damage as well. So when it's acute fulminating, patients will have signs of what acute signs of pain or acute signs of osteomyelitis. So throbbing pain, severe throbbing pain, patients will experience that. They'll be having these chills, yes, fever, extremes of temperature, and then also there will be the discharge as well. The area will be tender and then swollen. Then there's this delayed onset. Of course, there are acute fulminating. The stage 1 occurs during the first 3 months of surgery or after surgery. After patient have had surgery, or maybe patient have had any trauma. Yes. Then afterwards, maybe after healing has taken place, within or after the 3 months period, patient may be experiencing that, right? Or during that first 3 months period, patient will be experiencing that. So they'll have what? Drainage, I said pain, tenderness, and then maybe blood, hematoma buildup. Then the stage 2, delayed onset. Delayed onset, that occurs between after the first to 3 months. So stage 2 will be 4 months upwards, 4 months to a year, 24 months to a year after surgery, right? And then after any damage, and then healing has taken place. Then stage 3, that will be occurring 2 years or more after any damage or any surgery has been done. And then for stage 3, mostly it occurs as a result of hematogenous spread. When you talk about hematogenous spread, it's a bloodborne, right? Bloodborne, so through the blood. So let's say healing has taken place, everything is okay. We should know that bone healing takes stages as well. And so at the final stage, the remodeling stage, it takes a while before the bone will be smooth. Yes, will fall in place. And so always with osteomyelitis or with infections of the bone, if it's hematogenous, you see when the organisms or the bacteria are running through the blood, when they find a place where they can hide, it is more of the not so smooth surface or the curved surface, That's why mostly for osteomyelitis, it occurs at the metaphysis of the bone. And so when it happens that way, even late after 2 years onward, if patient has an infection, let's say tonsillitis, let's say any candida infection, any strep infection, anything at all, yes, then it runs through the blood, and patients may get that start within that area of the bone, and then infection can set in again. So mode of infection, we have the contiguous focus. So when you talk about contiguous focus, adjacent, sideways. So there has been a soft tissue infection that has been extended to the bone. A soft tissue infection that has been extended to the bone. Right? So let's say there's a wound and then poor management, and then it affects the bone as well. Let's say there is pressure ulcer, and then extends to the bone, right? Let's say diabetic ulcer, for instance, it can also extend to the bone. Then we have the hematogenous spread. I think I talked about that as well. So infection, say tonsillitis, the boils, even teeth, infected teeth. Yes, that one also, bacteria can now run through the blood and then into affect the site. And then we have direct bone contamination, maybe from traumatic injuries, open fractures, gunshot wounds, and all that. Then it can affect the bone as well. I think generally I've talked about the pathophysiology already. So the metaphysis is the common part of the sites where osteomyelitis can affect, and it's mostly also in children. It affects the children when it is the metaphysis. It affects the children. That's a common site. And then there's blood flowing, slowing down around the vascular loops of that area. Yes. And then when it happens that way, it encourages the deposition of what the microbes, the organisms, and then it establishes what infection, right? So there's inflammatory response which is created, and then it forms what pus formation, leading towards an abscess formation, right? And then the pus ruptures through the cortex to the periosteum. So now that it has to now ooze out to be discharged. So when it happens that way, the periosteum is destroyed, it impairs blood supply. There is what build-up of that. I've said that there will be, the blood supply, the pus and the abscess will now press on the blood supply in the intramedullary cavity. And then generally it will cause what? Dead bone formation, which is called the sequestrum. Sequestrum. Yes, sequestrum will form. And then when it happens that way also, there will be new bone formation over that injured periosteum called what? The involucrum. Is there any question? Can we move on? Is there any question? Can we move on? All right, signs and symptoms. We have the systemic, we have the local, chills, fever, rapid pulse, general malaise, rapid, okay, I find it's also here again, restlessness, night sweat, nausea. These are systemic, and then we have the pain also. For the acute, I explained that the pain is more throbbing, right? We have tenderness, we have swelling, warmth, and then drainage at the infection site. Any questions? Why do you think we do bone biopsy? Why bone biopsy? Yes, my dear Benjamin. Why bone biopsy?
Good morning, madam.
Yes, sir.
Please, I think we do the biopsy to identify, to pick out samples to identify the actual cause of, or the actual organism that is causing the infection or the osteomyelitis, so that we know how best. So we do culture and sensitivity, so that we know how best, and then the best, listen, antibiotics or the effective ones to cure the infection, and also to rule out any cancerous conditions. Thank you.
Okay, thank you very much. Thank you too. Any other? Any other? Okay, so identify the cause, pleural malignancy, so identify the actual microorganisms. Okay, to know if there is cancer or not. And I think that's what Benjamin also said here. Okay. What about ESR and then CRP? I talk about them all generally. What about ESR and then CRP? What about wound culture? Rule out infection. But read more about them and the labs. ESR to identify infection in RBC level. Yes, so Luke is quite close. Yes, so read more about the diagnostic investigations, right? So read more about generally why biopsy, and which one is even the main investigation that's supposed to be done to rule out osteomyelitis, and then find out why bone biopsy of course, we all have the idea about it, but I want be quite specific, right? So why bone biopsy, wound culture, ESR, CRP, and the differences between the ESR and then the CRP as well. And then differences also between the wound culture and then the bone biopsy, right? All right. And then the MRI and the CT scan as well. So why MRI, why CT scan? And then the differences between the MRI and then the CT scan. Okay, I think we can move on. That's okay. Right, so management, we want to do antibiotic therapy. That is the key, of course. We know that it's infection and infection of the bone. And even without infection, we've said that for bones, whenever it's affected, we have to give a shot of antibiotics. So how much more now that we know it has what there's an infection. And so we want to give what antibiotic therapy, we want to give analgesia. And then for their antibiotic therapy as well, we want to also do a full course of antibiotics, and it's IV antibiotics. IV antibiotics given as a full course. We want to give that one as well 2 to 4 weeks. 2 to 4 weeks. And if you want to go long, especially if it's chronic, then 6 weeks and above. If it's chronic, 6 weeks and above. And thankfully, you guys have also taught me, yes, let me use that word, the second and third generations. Yes, so you are still doing pharmacology too. So you are doing, I'm sure you all had A in pharmacology. Or your last semester results is not yet in. So this one as well, I would talk to Dr. Brukran to give all of you A's. Anyway, so that's great. Thank you. Yes, so we'll do a 2 to 4 weeks short if it's acute, and then if it's chronic, it's 6 weeks and above, right? And then, of course, we have to do what? Analgesia. Sometimes they can also even surgically expose the bone, and then they would do an incision and drainage, and then take out all the necrotic materials, and then of course do an irrigation with sterile solution, and then now in a way impregnate antibiotics inside the wound for a direct application of that for close to 2 to 4 weeks as well. They can do that as well. So that will be a direct application, or better still, the IV antibiotics. Okay. So we can do debridement and then sequestrectomy if it's chronic. So we want to take out the dead bone. Can we move on? We have to, right? Okay. In terms of prevention, we should know that we said that infection prevention is the key for this, even before touching patients in the first place, before managing patients. So we have to pay particular attention to the surgical environment and the techniques to decrease bone contamination. You know that when staffs have even common cold, ideally we are not supposed to go close to patients. Do you know that? How much more for surgery? And so if patients have surgical, we're undergoing surgery, and then more especially for bones or brain, all those, spine, all that, we would need to do away with any source of infection, right? So we have to get the surgical environment very clean. Prophylactic antibiotics, sure, that one we talk about it generally. Catheter care. You see, also for these kinds of surgical interventions for patients to prevent infection of the bone, right after surgery, their catheter is not supposed to be in situ after 24 hours. Their catheters and then drains are supposed to be removed as soon as possible to decrease the incidence of what? Hematogenous spread. Yes, blood-borne spread. Maybe the wound drain can be there for a while till the drainage has been cleared. But for catheters, after 24 hours, for urinary catheter, after 24 hours, it has to be taken off. And when we are doing post-op management for orthopedic, we realize that we are not supposed to let patients stay in bed and say, oh, because they have done bone surgery, or they should be in bed for long, blah, 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 blah. No, right after 24 hours, they're supposed to get up and ambulate. Of course, it would help, right, with assistive devices. Then, of course, wound care, we have to do proper wound care for our patients, aseptic wound care for our patients to reduce any superficial infections, right? Okay. Patient's response to antibiotic therapy, we have to, Mr. Lassan, give me just a moment. We have to ensure that our patient is monitored. We have to observe that observe their response to antibiotics. We have to observe the IV sites, whether there's any infection, phlebitis. We want to still prevent hematogenous spread, right? Yes, and so we want to also check for, because of the long-term infection, long-term antibiotic administration, also want to prevent any super infection. Somebody was rightly asking, how can we even tolerate the resistance, right? So we monitor also for any infection or any super infection as a result of too much use of the antibiotics. So any thrush, candidiasis, oral, vaginal, their feces, whether loose, foul smell, and there are lots. You can go and read more about that as well. Then any sudden increase in body temperature, that can also shows that, or if there's any even painful or tenderness anywhere else apart from even at the site of the surgery as well. So if there's any spike in temperature, if there's any pain or any tenderness within that area, patient needs to be monitored very well. Yes, Mr. Alassan.
Good morning, madam.
Yes, my dear.
Madam, please, my question is like, with regards to the removal of the catheter, urinary catheter. So, for patient with traction, they did traction for the patient. The patient is going to be on the bed for some quite time. So I don't know whether for that patient, are we going to like remove the catheter or like within the 24 hours, or we are just going to leave it, or for them? That's just, I'm confused then. So I just want clarity there. So that's why
Okay, thank you, my dear. What do you think? Even though we'll treat traction as well, but not today. You see, ideally, if anyone wants to come in, that's fine. That's fine. Just I want to see if I can cut 10 shots and then the group one will come and present. So I'm almost done. You see, ideally, what do you call it? Yes, traction is supposed to be, it is not really a cure. It is preparation for the real surgical intervention. It is something just for the moment to just keep the bone in alignment in preparation for the next stage of surgery, right? So in a way, and then apart from that aspect as well, our aspect, we as nurses, ideally, you see, we have to care for our patient catheters. We don't do that. We don't. With that one also, I think when you are doing your nursing practice next semester, maybe whoever will take you go through with it. We don't do it. And so ideally, if we are supposed to do our proper care well, because they are in bed, because traction, they can't get up. Because they are in bed, we are supposed to monitor them. We don't do that. We are supposed to care for. We don't do that. And so ideally, before we realize, we are rather introducing more harm than good. So we are supposed to take it out and then assist patients to be using bedpan. That is the ideal thing. Ideally, that's I've used the word ideal, but of course we can, because we're not doing the right thing in a way. Sometimes we want to just overlook some of these things, but we are supposed to take it away and then put patient on bedpan as and when, then also prepare patients to the next stage of surgery. And so patients shouldn't be in bed for so long for traction if we are anticipating some other step of surgical intervention. Okay, thank you very much. I think we can move on. Patient teaching. So we teach, I think this is all we're talking about the general care. We talk about it. Adhering to the treatment regimen, reporting signs of infection, education. Yes, personal hygiene, follow-up visits. So preoperatively, nursing management, before we do our sequestrectomy or incision and drainage or the debridement, we'd want to do the general management of musculoskeletal surgeries. Postoperatively, my dear Daniel, I'm coming, give me a moment. Postoperatively, you want to relieve pain. You want to, the goals, of course, improve physical mobility. And then we want to control and eradicate infection and then get patients more abreast with their treatment regimen. And so we want to ensure that patient has adequate circulation. Wound suction can be done, but that one also comes with a cost. And so we want to elevate patients' limb to promote venous drainage, right? And avoid any pressure. If there's bone grafting, we want to avoid any pressure. When we are dressing, it has to be firm and not tight. We want to maintain mobility, comply with weight-bearing restrictions when patient is supposed to bear weight, mostly with bone healing, unless with evidence of X-ray, so we know that there is alignment before we let patients start bearing weight on the affected limb. We don't just get up and say, oh, it's been 2 weeks, it's been a week, so now start stepping on it. No. Even if we say patients should ambulate, yes, but they use the restrictive assistive devices. And it depends. We are going to very soon learn about the 2 gates, the 3 gates, the 4 points of gates in walking or in ambulating. And so based on the weight restriction, we know that patient is supposed to use the 2 gates, the 3 gates, or the 4 gates, or better still, we even have the swing through and then the swing through as well. Then dressing changes, we have to do that using aseptic techniques. These are the complications. Any questions with this? Any questions? Very move on. Abscess, bone deformity, systemic infection, contiguous spread, septic arthritis, pathological fractures, squamous cell carcinoma, and then sinus tract infection. And then these are the lesson diagnosis. Daniel, someone's hand was up. Was it Daniel? Oh, you're okay.
Madam, I'm okay.
Thank you. Group 1, can we come in? Any questions? Any questions? Group 1, are you ready? Okay. Group 1, are you ready? You're not ready. Mr. Imanolata, where are your group members? And then Rebecca. Yes, where are your group members? Where are your colleagues to present group 1?
Hello, madam. I think they are there, but then I don't know. Maybe we personally, I didn't even see that you have uploaded it on the V class. Yes, please. So it has catch us by surprise a little.
Oh, my dear. Seriously. Yesterday, last week, but I said it. I said it last week that this week group one will present, right? Or I didn't say it
Yeah,
in class.
you said you will be presenting alongside whilst you are lecturing.
Yes, and then I also said that group one should get ready. They would present. My class is so packed that for me, I don't know how to leave some topics and behind and then the semester ends. So I always try my best so that we fit in within that period. I don't know whether we have 8 weeks or whatever period. And you see, within this week also we have mid-semester breakage. Sometimes network may be disturbing. There'll be this morning I had even light out. Just about 10 minutes to time or 5 minutes to time it came. So there are unforeseen circumstances. So
Yes,
if we are just behaving this way, it wouldn't help us.
yeah,
And I
madam, please.
went, your Badmi January cohort, okay, of course, this is your second semester. I realized that you have to even go to the V class to log in or to join class. So if you're able to join class in the V class, and you're saying that you didn't see, I think I uploaded the course outline last week today, last week Sunday, right after we met. And I uploaded it. So it's a week. Do I also say that I wouldn't be prepared and then come to class? Anyway, 1 hour, the next presentation is 50 slides. And if you want me to use 1 hour to treat that with you, that's fine. Let me just go on. We are going to talk about fractures.
Madam, we are ready. We will present. We are ready.
So you see, who was talking? Look.
Madam, look.
Yes.
Group one.
Yes, look.
We
I
are trying
called
to
out
get
your
them.
name, group one, several. Please listen to me. Several. So Luke has unmuted, Gifty has unmuted. I've called out your name severally. No one responded. Now I want to, should I say, share a slide. Just tell me, sister, we are ready. If you want to say madam, fine. Madam, we are ready. Don't say madam, we are ready. Oh, it's like, it's an insult. Please. Because I called your name, you didn't even respond. So if you are ready now, just say it in a nice way. I don't want respect from you. You also, I don't need it from you as well. But I'm trying to give you, we should get a bit of mutuality here. I don't need madam ready. Oh, no. And I'm not yet a doctor, please. I'm sister. Thank you. So please upload or please share.
Thank you. We are sorry for that.
Don't worry.
Please, should we share to you or
No, share. You can, I think you have the, I don't know, you can share. There is no restriction.
please, any member can share. Please, if you can share, any member can share. Some.
Please, any member can share. That's what he said.
Okay. Please, we are group 1. Look, I'm the one presenting for now. We are going to talk about some of the musculoskeletal conditions. And the first one that we are going to talk about, please, let's go, is scoliosis. Scoliosis is a sideway curvature of the spine, mostly greater than 10%, and causing either the X or the C shape to be deformed. So if you look at the diagram, you could see that it has the spine has shifted in a way you can even assume that it is what is it that C shape or what the X shape. So if you have a curvature that has been curved like that, we consider that one as scoliosis. And mostly the incident is about 2 to 3% of adolescents, and more common or more prevalent in females as compared to males. The causes or the etiology, mostly the cause is unknown, and the causes and the type are even the same. So what causes it becomes the type. So the etiology, the idiopathic, meaning we don't even know what causes it, but we know that some also attribute to genetic factors. Okay, and then we have congenital. You can give birth and then the child may have that kind of spine, either the S or the C shape. And then some of the neuromuscular disorders, like someone may have let's say multiple sclerosis, and because of that it can predispose the person of getting what? Scoliosis. Trauma, someone can have an injury or infection or tumors in the spine, which can also causes the scoliosis. Age related, as we are aging, our cells and then our nerves have become what? Degenerated. And mostly if you look at those, especially the tall people, if you look at them, even though they may not have any condition, but because of the age, because of the degeneration, their spine begin to what? Curve. Please, let's go. The types, as I was saying, the types or the causes becomes what? The types. So we mentioned what? Idiopathic, we don't know the cause. So one of the type of scoliosis is what? Idiopathic scoliosis. That means we don't know what is causing it. Mostly it commons in infants, those that are between the 0 to what? To 3 years. And then the juvenile or the juniors, that is 4 to what? 10 years. And then adolescent, 11 to what? 18 years. We can also have congenital, as I was saying. Once someone can give birth, and then you may have that kind of deformity from birth. And then neuromuscular sclerosis, it could be as a result of cerebral palsy, multiple sclerosis, or muscular dystrophy. When you're unable to use your muscles well, it can also what? Curve. Or maybe someone who's having nerve problem, cerebral palsy is also another type of what? Scoliosis. And then degenerative what? Scoliosis. As I was saying, once we are aging, our spine or our nerves begin to degenerate, which will lead into what? Scoliosis. So let's see some of the clinical manifestation or the signs and symptoms when someone is having scoliosis. We said uneven shoulder or the hips. So you could see that because of the curve of the spine, the shoulder become what? Uneven. One will be what? At the top as compared to what? The other one. And then if you look at the waist, because of the curve, they have what? Unsymmetrical what? Waist. It will not be equal. And then they will have severe back pain. It's mostly common in what? In adults. Okay, because of the curve of our spine. Severe cases, you may see some difficulty in breathing. Looking at where our lungs is being found, our lungs is found in the thoracic cavity. So once the spine has been curved so severely, or the condition is so severe, it's going to compress the lungs, which find it what? Difficult to breathe. Okay, so as I was talking about the uneven shoulder, if you look at the picture, you could see that one is at the top as compared to what? The other shoulder. And the uneven waist too, you can see that it is not balanced. This one is down and this one is what? Is top. Please, let's go on. So some of the diagnostic investigation that we can carry out to rule out scoliosis is physical examination, once you observe the person and you can, with the signs and symptoms, you do your physical assessment, you could see that, you could be clearly see that, oh, this client is having scoliosis. You can also do spinal x-ray. So when you do your spinal x-ray, you are going to see the curve, as I was mentioning, the X or the C shape, you are going to see it in the X-ray. So that one can also diagnose scoliosis. And then MRI, you can do MRI. Remember, we were saying that one of the causes or one of the type is what? Degenerative what? Or neuromuscular what? Scoliosis. So once it's affect the nerves and you do the MRI, you'll be able to what? See what is happening, or you can use the MRI to diagnose because of what? If it is as a result of neuromuscular or degenerative. So medical management basically is a surgical condition, but anything that you do without using surgery, a terminal one as what? Medical, management. So we can use braces where, as we can see in the picture, braces where they will use, they will just wear the client and then it will cover. They just want to straighten what? The spine. Okay, so moderate, if the condition is as a result of moderate, we can just use a braces to correct what? The deformity. Okay, but if it is so severe, then they have to do what? Surgery. We can also do observation. You observe the client, you observe the curve, and then you ask the client to be coming forward, follow up, to do checkups. And then we have physiotherapy. We can posture exercise, specific exercise that can strengthen what, or that can correct what? The spine. And then we can do pain management. Remember, if there's pain, we manage. You can give analgesia as the client complain of pain. Please, let's go. So from there, if it is severe and the medical or the using of the brace is not able to treat it or is not able to correct the spine, we zoom into what? Surgical management. So the surgical management, we are going to spinal fusion with instrumentation. We can use either screws, rod, and to correct what? The curvature. So basically in orthopedics case, maybe they can use screws and other wires and other this thing to join together to improve the balance, because at the end of the day, remember, because of the C shape of the spine, the client is not balanced, is not able to have equilibrium. So once they do the surgery, they are going to correct that kind of deformity. And before surgery, we know we undergo preparation for the surgery. So the preoperative, you are going to support the client psychologically. You are going to assess the respiratory distance. Remember, we say in a severe case, it's going to compress the lungs where the client is going to find it difficult to breathe. So you need to, do lungs, pulmonary function test to know that the client is having enough, volume capacity. And then you educate the patient and then the family about the surgery. You lay any anxiety or any pain, you can give pre-medication for the surgery. Okay, and after the surgery too, you can monitor the vital signs, neurological status. You check whether there's numbness, is there anything that has been affected the client after the surgery. Pain control, as you are saying, you are also going to control pain, because after surgery, definitely there's going to be pain. You care for the wound and then make sure that you prevent an infection. You assist with mobilization. Once the client after surgery, we encourage the person to be more ambulating to prevent any complication like vein thrombosis and other distance. Okay, respiratory exercise. Respiratory exercise is basically mostly we teach the client before the surgery. So you tell the client, you teach them how to do deep breathing exercise, or you can even give incentive parameter just for the client to be able to for the lungs expansion, because of the anesthesia mostly that you give before the surgery. So the complications, we can have a chronic back pain if the correction is not being made, or even the correction can be made but it can result into a chronic. So this complication could be either after surgery or we didn't even result into surgery. So the client can lead into, because of the acute pain, can lead into chronic pain if it persists for a very long time. Cosmetic deformity, yes, especially our women, when they have this kind of deformity, you can imagine their beauty, and then cosmetically they have some more deformities. Reduced lung capacity, as I was saying, So once there's no correction for the spine, and it keeps on compressing what? The lungs, it will lead into what? The lungs' ability to hold oxygen. Okay, so that is scoliosis. So we are going to kyphosis. Please, let's go. So the kyphosis is excessive outward curvature of the thoracic spine, giving a rounded appearance. So the first one was what? The first one we're talking about was giving out what? An X shape, but this one is giving us what? A rounded appearance. Mostly the incidents are more common in adolescent and increase as you are what? You are aging due to osteoporosis. Osteoporosis are mostly common in adults or in older age. The etiology, the causes of kyphosis. Poor posture. When you are in the ward and you are lifting patient and you are not observing, the body mechanisms, and due to that, every time that you are lifting patient, you are just positioning yourself anyhow. That is poor posture. It can expose you to what, or it can cause what? Kyphosis. Vertebral growth abnormality. When your vertebra is just growing and then it's not growing the way it's supposed to be, it can also predispose you of getting kyphosis. And someone who is having osteoporosis, especially the older adult, they are more likely of getting kyphosis. Spinal trauma, maybe they were doing lumbar puncture or anything that can, affect your spine, or any trauma that can affect your spine, or maybe there's a fracture. You had an accident and there's a fracture. It can lead into what? Kyphosis. Infections. You have infections, and as a result of that, it can affect your spine, which lead into what? Kyphosis. And this one too, degenerative or disc diseases. So you can have a disease that can also affect your spine and can lead into the rounded appearance of your spine. So let's look at the types. We have postural kyphosis. That is the most common due to what? The poor posture, flexible, often in adolescent, because anytime that we are doing, mostly is the adolescent that mostly affected of this condition due to what? Our poor posture. Okay. We have congenital kyphosis, when the person you born, you give birth, and then there's what? Malformation of the vertebra, which lead into what? The kyphosis. And we have age-related degenerative. As I was saying, once you are aging, you have problem with what? Osteoporosis in your bones, which lead into what? It can also even lead into pathological fracture. Okay. And then we have secondary kyphosis. This is due to trauma or infections or TB of the spine, tumor or neuromuscular disorders. So it could be as a result of some infection or some trauma that will lead into what? The kyphosis. That's why it's a secondary. Okay, maybe someone have tuberculosis and it lead into what? To affect what? The spine. That lead into the kyphosis. So let's look at some of the clinical manifestation or the signs and symptoms. You have a rounded upper back or the hawk posture. So when the person is standing, you could see that the back is what? Is like a horn. Okay, it's like a horn. The back is a horn. And then the back pain and stiffness, they will have a strong back pain. And then it's what? Stiff, fatigue. Any small thing that they engage, they become tired. Muscle weakness. Okay, is that as a result of, let's say, the osteoporosis due to the old aging? The bones and then the muscle becomes what? Weak. In severe cases, this one too, it can lead into what? Difficulty in breathing because of the restriction of what? The lungs expansion. So the diagnosis is that the same thing as we talk about in scoliosis, is the physical examination. You can see with your naked eye, and then the X-ray of the spine will also what? Determine it. And then the MRI is as a result of congenital or neuromuscular what? Related cause. You will find it in what? In the MRI. Please, let's go. Okay, surgical management. Spinal fusion, or you can do spinal osteotomy. So the spinal fusion here, they are just going to correct the kyphosis. They are just going to fuse what is causing the kyphosis. That is the spinal fusion. All right, so the medical management, I said anything aside what? Surgery. So you can do observation, can observe the person, and you can give any anti-inflammatory drug for the pains or analgesia for the pains. You can also do physiotherapy. Yes, you can do push-up. As you can see in the picture. So the push-up question, they are just strengthening exercise. They will just sound as those physiotherapists, they will just strengthen, engage you in an exercise that can strengthen what? Your spine. And then we can use the braces, especially in adolescents. So we can use the braces to correct what? The spine or the kyphosis. So the nursing management here, because if you are going for surgery, we have to prepare you pre-operatively. So we have to educate the patient. We have to educate the patient about the condition, assess the pain level, the respiratory functions, and psychological. We have to prepare the person to allay any anxiety. And then after the operation too, we have to do pain management. We have to monitor if there's any neurological, status or any neurological disorders like numbness and stuff. We have to also dress the wound. Wound care is very important just to prevent an infection, and we have to ensure that we encourage early ambulation just to prevent infection or any DV or maybe pulmonary embolism. So the complications, they are the same thing as we talk about in scoliosis. So chronic back pain, if it is nothing is being done about it, reduced lung capacity or the lung function because of the compression in the lungs. Spinal cord compression mostly is rare, but it's very serious. So once you are not doing anything about the condition, it can lead into compression of your spinal cord. That's a severe and emergency cases. Psychological distress due to body image. So once you see like this, you can't even go when there's your peers are even having conversation or going out because of your body image. So psychologically they become distressed. All right, so the next one that we want to talk about is lordosis. Lordosis is a spinal deformity characterized by increase in inward curvature of the lumbar spine beyond the normal range. Remember, the kyphosis was what? Outward. But the lordosis is what? Inward curvature of the spine of the lumbar spine beyond the normal range. So the incident is more common in pregnant women, those who are obese, that is overweight, above 30 BMI, and those with poor position or poor posture. It can also occur at any age as compared to the kyphosis that mostly those with older ages that are mostly affected. So the etiology or the causes, one, poor posture or poor position. When you are not following proper body mechanism, you are likely or you are being exposed to lordosis. Obesity. Once you have more than over 30 BMI, you are going to put a lot of pressure in your spine, which can lead into lordosis inward of your lumbar spine. Pregnancy, once you are pregnant, you are being predisposed of getting it. Weak abdominal and then the core muscles. So once you have weak abdominal muscles, it can also predispose you to spondylolysis. This one is a condition or an infection of the spinal cord. So once you get an infection of the spinal cord, you are likely of exposed to lordosis. Hip disorder, when you have any condition that can, or any trauma or any infection that lead into your hips being affected, it can also lead into lordosis. Spinal injury or spinal trauma can also lead into that. So the types also follow as a result of the cause. So if it is as a result of poor positioning or poor body mechanism, we call it postural lordosis. If it is as a result of congenital, is congenital lordosis. That means you come when you were born with it. Or the lumbar lordosis. This is most common and affect the lower back. The secondary It could be as a result of any condition that lead into the lordosis. So you develop maybe any spinal condition, like maybe someone is having scoliosis or maybe hip disorder that lead into the lordosis. Trauma or any pathological lordosis. You have trauma to the spine, and as a result of that, it lead into what? The lordosis. All right. So let's look at some of the clinical manifestation of lordosis. Exaggerated inward curve of the lower back. Remember, we said that the lordosis is what? Is an inward curvature of what? Of the lumbar distance. So once there's an inward, you could see that we said it's normal more than what? The normal range. The inward is more than what? The normal range. So you could see with your naked eye there's what? Inward of what? The lower back pain. You can see that protrusion of what? Abdominal and then the buttocks. So this one, you could see the protrusion of what? Of the abdomen. That's what it's trying. The abdomen comes out like that. Okay, as like the person is what? Like the person is pregnant. Lower back pain, because it affects the lumbar distance, you have a severe lower back pain. You can have stiffness or muscle fatigue due to the muscle weakness. Reduced flexibility. So when there's an over inward, you see that the body or the muscles or the spine will not be what? Flexible again. The diagnosis is the same thing. Physical examination, you can see with your naked eye. So you can see in the diagram what is trying to, the picture, I'm trying to talk about. And then you can also do an x-ray. The x-ray will, detect how inward the spine has been. And then you can also do MRI if there's any nerves involvement or you are suspecting as a result of any neurological issue. All right. So medical management, we can give our NSAID for pains. We can also talk about weight management. Remember, we said obesity is one of the causes. So once the person is having overweight, we can put the person on diet or maybe exercise or any medication that can reduce the cholesterol level. We can also do physiotherapy just to, strengthen or teach the person how to position. Because remember, we said position is one of what? Poor posture is one of the causes of what? The lordosis. And then the surgical, we can also do braces as well. And then surgical management, we can do spinal fusion if there's severe, we can do. And then we can also do corrective for surgery just to correct what? The deformity or the lordosis. So the nursing management here is the same thing. Pre-operative, we are going to educate the person, pain assessment, posture education. We teach the person before the person undergo what? The surgery. Psychologically, we have to psych the person to reduce anxiety, and then after the surgery we have to control the pain. We have to monitor if there's any neurological disorder that has been occur as a result of the surgery. We assess the person to ambulate just to avoid any complication like DVT. Wound care, we have to make sure that we dress the wound to avoid any infections. So the complication, chronic, if nothing is done, the acute will lead into chronic pain. There's going to be disc degeneration. Okay, so once you're not doing anything and the nerves keep on compressing, the lordosis keep on inward, it leads into disc degeneration, nerves compression, and can reduce mobility because of the protrusion of the abdominal muscles. All right, and then the next one that I want to talk about is osteogenesis imperfecta. So it's a hereditary disorder caused by defect in type 1 collagen leading to bone fragility and skeletal deformity, or it's a genetic disorder causing fragile bone due to defect collagen. We know collagen helps us in what? In bone healing. So we have a situation whereby you give birth and they have that defect of that collagen. So mostly once you lack collagen, especially type 1, it leads into fragility of what? Of the bones. And with any small thing, it lead into what? Fracture. Okay. So mostly the incidents occur in 1 in 15,000 to 20,000 birth, affect males and female equally. So it tells you that it's not that common. Genetical mutation that occurs. So we can have as a result of genetic mutation, where commonly in COLA1A1 or COLA1A2 genes. So mostly when you have that mutation, you are predisposed of what? Getting osteogenesis imperfecta. Usually is an autosomal dominance and sometimes autosomal recessive. So here, what we are talking about is when someone is having, when the two parents can have, maybe the mother can have that defect in that genes, and then the mother too, and the father too can have that defect of that gene, or it could be as a result of only one, and they can give birth to such person. There's going to result in reduced or defective type 1 collagen. So as we were saying, that is caused by what? The type 1. So when there's a reduce, or when there's a defect in type 1, we said you have that condition. So types or the classification, we have MAR. So most commonly occur, we have bruised sclera, few fractures, and normal lifespan. So here it is not severe. They have fewer fractures. So fewer fractures mean, that means the remember I mentioned that the type 1 collagen help in bone distance. So once you have a few of them, or there's a defect, there's possibility of being exposed to what? Fractures. So here the fractures are what? Small, or they don't have frequent what? Fracture. Okay, and mostly they live to what? Their normal lifespan. If you go to the type 2, that's a severe lethargy form, multiple fractures at birth, severe skeletal deformity. So here, during birth, they can have multiple fractures and can lead into, and once you have multiple fractures, can lead into what? A lot of skeletal deformities. Type 2 is severe. Progressive deformity, very short stature and frequent fractures. So here it's progressive. So from one deformity to the another, and it's very severe. That is a type 3. And then a type 4, that is a moderate. Variable severity, normal scleral bone deformity, they are all what? Present. So that is the moderate one. So let's see some of the signs and symptoms. Recurrent fracture with minimal trauma. So even with any small thing, anything that maybe a normal person could have, not sustain any fracture or any injury, such person or what? Who sustain fracture. So, and it keeps on occurring with any small thing, the person sustain what? Fracture due to the defect in what? Collagen type 1. Bone deformity. Once there's fractures, what leading to what? Continuous fracture leading to what? Deformities. Bruised sclera. So if you look at the eye, you see that you see some bruise kind of in the sclera of the eye. Short stature. When you look at them, they are not tall, they are very short. So mostly that's their appearance. Hearing losses. It could be either conductive or what? Sensorineural. So mostly they have problem with the hearing. Dental deformity. So they can have dental defects as a result of the collagen type 1. All right, they also have muscle weakness. So once you have multiple distance and you keep on healing and keep on distance, so leading to what? Muscle weakness. The diagnosis, we can do history of recurrent fracture. The person will come and complain to you that I've been having fractures all about, maybe any small thing that I engage, I sustain fracture, or I sustain injury. So when you do X-ray, osteopenia, fracture deformity, you can see that when you do an X-ray, you see that wherever that you take the X-ray, we see that there has been a continual or recurrent fracture of that particular place for a very long time. So because of that, you can be able to detect, you can be able to think of what? Bone density studies. So when you do your bone density, you are just going to, the masses of the bone, how thickness or how this thing is it. So when you do bone density studies, it will also show to you due to recurrent distance. So they have low bone density. You can also do when you know that this person or this parent are having this condition because they're autosomal recessive, they can take an X-ray to determine whether, they are in this, they will give birth to a severe or they will give birth to a child that is having this particular condition. So they can do an ultrasound whilst the person is pregnant. So medical management, they can give bisulfonate that increase the bone density and reduce the fracture. So it's a form of like a calcium kind of this thing. So they will give, mostly these medications are given with food. So they will give to increase the bone density, given to increase the bone density. You can also give calcium and vitamin D or supplement, okay, just to strengthen the bones. And you can do physiotherapy just to strengthen the bones, and you can do rehabilitation, all of them just to strengthen the bones as the client can tolerate it. Remember, we said there's hearing problem, so you can do hearing assessment and dental care. You can assess the person and you refer to as expected. We can do surgical management, intramedulla rolling of the long bone. So orthopedic surgeon can go in there and then, join the bones together. Intramedulla, they just go inside the bones and maybe use a wire or something rod to join the long bones. And then the fracture fixation, when especially within the long bone. So when the client is, remember we said is multiple fractures. So the surgeon can go there and then join the bones together. Fixation, they will just join it together. The nursing management, general care, we have to handle to prevent fracture. Remember, these people, they are more prone to fracture. So when you are taking care of them, you have to handle them with care. Anything that will predispose them of getting injured or fracture, we have to avoid it. We assess the pain and then we'll manage it. So once you assess the pain using the pain rating scale, so whatever pain the person rate it, then you give your pain medication as expected. You position the person very carefully. Okay, when you are positioning the person, you have to be very careful using proper body mechanism, and make sure that when the client is ambulating, you assist the person just to prevent fall and recurrent of the fracture. You educate the patient and then the family, and then genetic counseling. You educate them if there's a need for them to, cease giving birth, because once both of them are recessive and both of them are having the mutation, if they keep on giving birth, they'll keep on giving birth to such clients. So it's advisable you counsel them either to halt their birth. And then preoperatively, you just assess the fracture history, psychological preparation for the surgery before you send the person. And then post-operative, after the surgery, we have to monitor for complication as usual, because the fact that you have undergone surgery doesn't mean that they cannot sustain injury again. So you have to monitor them for any reoccurrence of the fracture. You assess with rehabilitation. You let the person walk small, strengthen the bones and other things small as the person can tolerate it. You prevent infection and immobility complication. So you make sure that you ensure early ambulation just to prevent DVT or any pulmonary embolism, by making the client, assist the client to walk as tolerated. So the complication, it could lead into recurrent fractures, as we were saying. It can lead to skeletal deformity. Once there's recurrent fractures, it lead into skeletal deformities. And chronic pain, if nothing is being done on it, can lead into chronic pain. Hearing impairment can lead into dental decay. Remember we said the tooth is being affected, so it can lead into that. So please, this is the end of our presentation. Thank you.
Great. Great. You've done very well and you've really worked within time. That's great. Very great presentation. Okay. I asked the group to raise their hands. No one did. So I've just recorded Luke Frimpont's name. That's it, right? All right. So, any questions for the group? Any questions for the group? All right. So, 20 minutes more. Look, can you kindly stop sharing? Let's see if I can use the 20 minutes to do a little bit about, of course, I won't finish though, but the fractures, I can take some few slides away. So that next week will be on time as well. Do you have any questions for the group before I upload my slides? Do you have any questions? Okay. Your presentations, I'm thinking about it. I don't know. Maybe it will be used either only for your mid-semester exam, and you and I also know that your mid-semester exams, you use AI to do your exam, right? And for me, those scores, I don't necessarily use it so much. Yes, so that's just about that. But anyway, so I'll see if it's going to be just basically for the mid-semester exam, or I'll bring part of your presentations in my end of semester exam. I'm thinking about it.
Hello, madam.
Yes.
Madam, please, I don't know, but whenever I raise my hand, I don't know whether it's not saying. So please, thank you for the opportunity. I want to ask a question from the group one presentation, please. Yes, please. When he was presenting the last presentation, the last condition, he mentioned that the signs and symptoms are short stature. I want to find out if it is the whole body that is shortened. For example, excuse my language, in the case of adjustment and the friend, or it's just a particular part of the bone which is affected that shortens.
Okay. Look, did you hear a question? Is it the whole body or there's a particular part that will be shortened?
Okay, thank you. I've heard the question. Yes, basically, it depends. Sometimes it could be the whole body. Sometimes it could be only the extremities, the legs. So that is what I know about it.
All right. All right. Thank you. So I think if there's anything you can read more about it, right? Yes, I think when he was presenting, I don't know, but it seems I heard something like that. Anyway, so fractures. I'm sure that I keep on saying when I'm presenting anything that, oh, you've heard it before, you've seen it before, you've nursed before. That's why I always say that. So fractures, yes, I'm sure that one also we've all heard it, we've nursed it before, we've read about it before. So what are they? Yes, a bit of a course. I don't know whether this lecture, when I was presenting, I wanted to be a really good teacher. And so I added on my learning objectives. So those are the learning objectives. It is a definition of fractures. We have it here as a break in the continuity of a bone, and it's defined according to the type and extent, just like wounds, right? Wounds break in the continuity of skin. So yes, even though the current definition for wounds has also been a bit elaborated. So yes, if there's a break in the bone, but then it's defined according to the type and extent. And so we have types, we have classes of fractures or description. We have the complete, incomplete, we have the open, closed, we have the displaced and non-displaced. And so we have it over here. So an open one, it communicates to the external environment, right? Yes, that's the open. It communicates to the external environment. Closed is found within. And so mostly for closed fracture, this is what we can do. Of course, this closed is also complete, but if it's closed and it's incomplete, you can do close reduction and then maybe apply a cast. But if it's closed and it's complete, it means I have to really do a surgical intervention and put in an implant or a plating or IM nailing. Then we have the displaced, so found within, and then non-displaced also within. Then complete or incomplete. So incomplete fractures, you all know that mostly it happens to the children, right? Yes, the pedics. And then we have the complete fractures. Everything, the both cortexes are broken. Both cortexes are broken, and then incomplete, just one cortex that has been broken. So one example is the green stick fractures for the incomplete fracture. Right, we have, now we are coming to the types of fractures. We have avulsion fracture, where the fragment of the bone has been pulled away by a tendon and its attachment. So you can see it on the screen here. And so for them also, you can see that they always do what I am nailing to put it together. So it's that kind of forceful detachment of that tendon from the calcaneum bone. You can see it there, right? It can be complete or it can be incomplete or partial. Then we have the comminuted fractures. So pieces of the bone fragmented. The bone has been splintered into several fragments. So comminuted fractures, you have it there. And then I think the picture you find it here also X-rays and all that with IM nailing. Then compression fracture for the vertebrae. Compression fracture, you can also find it over here on the picture. A fracture in which bone has been compressed. So seeing it in vertebrae. Then depressed fracture more for the scalps, and then more for kids. So a fracture in which the fragments are driven inward. So as I said, seen more with kids, and then for facial bones, and then the scalps, right? Then we have the green stick fracture here also. We have as I said earlier, one for the pedics as well. One side is broken, so one cortex is broken, the other side is bent. Then we have the impacted fracture. One end overlaps. One end overlaps in each other, a fracture in which a bone fragment is driven into another bone. We have the oblique fracture. So this occurs at an angle across the bone. So this is quite less. We have one also, the transverse fracture, where we have a bit of a difference, where the oblique is less stable than the transverse fracture. So you see it here, there's that break, there's that kind of curve. Then pathological fractures as a result of disease conditions. We learned about osteomyelitis some few minutes ago. Is one of the complications. So out of these conditions, cancers, tumors, whatever, I can just cause the bone to be fractured without any trauma, right? Then we have spiral fracture. Spiral fracture, twist, like an S, a twist. Fracture that twists around the shaft of the bone, a twist. So we have pictures also in here. Then we have the transverse, straight, right? So as compared to the oblique, you see that one that was the crack or the break was quite massive as compared to this. This one is in a straight line away. So the transverse fracture straight across the bone shaft. Now we have grades or grades for open fractures. We have the grade 1 clean wound less than 1 cm long. We have the grade 2 a larger wound without extensive soft tissue damage. And we have the grade 3. Even grade 3, we have also in grade 3 A, B, and C, right? So that one is highly contaminated. It has extensive soft tissue damage. It is the most severe out of all the grades, of course. And then it may also even be accompanied by traumatic amputation. When you have a grade 3 open fractures, then there may be traumatic amputation as well. All right. Causes. So for fractures, generally, it's all about trauma, Trauma. And so if it's as a result of disease condition, we've talked about the pathological fractures. So clinical manifestations: pain, tenderness, loss of function, deformity, shortening of the extremities. We have crepitus, localized edema, ecchymosis, muscle spasms. These are all some of the clinical manifestations you find. When you talk about crepitus, what do you think it is? Crepitus. Kindly find out. If you have it also, you can put it in the chat box. Crepitus. And then the ecchymosis. If you call it ecchymosis as well, that's fine. So find out, right? Okay. Any questions? Any question? I don't know if I should do bone healing or I should leave you, because bone healing is quite, I need to explain this one. I'm sure there'll be a bit of questions out of that as well. Do you have any questions with this, or we can leave it here? At least we talked about the types. So when we meet next week, you can know that we are going straight to bone healing. Yes, so crepitus, yes, sound head when there's a fracture, sounds, crepitus sound head in bones, yes. Right, that's great. And so when you're handling fractures also, you should know how to handle, I think all this we discussed, the crepitus, that's great. Cracking sound, that create, and then ecchymosis is same as bruises. Okay, can I get a better? Blood bruise caused by bleeding under the skin due to leakage of blood from damaged blood vessels. Right. Okay. Any questions? Any questions? So maybe you can, crepitation is most common in comminuted fractures. Okay. Maybe you can read more about bone healing so that next week you can just get the concept very well, right? What do you think are some of the factors that impede fracture healing, some of the factors that promote fracture healing? That ones you can also find out more. We'll discuss that next week. So bone healing, factors impeding or promoting healing, and then the diagnostic investigations for fractures, and then the management. Then maybe you can move on to talk about common joint surgical conditions, and then maybe fracture healing or post-operative management of fractures. I don't know, check the course outline if next week a group is presenting. But if not, please just get ready, group 2. I don't know if you present or not. Just get ready, right? All right. Any questions? Any questions? Okay. Have a wonderful Sunday. Bye-bye.
Bye. Thank you, madam.